Hello, everyone. And on behalf of the Pharmacists Without Borders, I would like to welcome you today to this webinar, which is one in a series of webinars called Cross-Country Conversations. And the series looks at how COVID-19 pandemic is impacting pharmacy practice across the world. This webinar today is going to focus on the specialty of intensive care. My name is Linda Carrol and I live in Winnipeg, Manitoba, Canada, and I'm the VP of Western Provinces and webinar lead for PSF Canada. I have the honor today to host this webinar and to interview two fascinating and dedicated pharmacists, one from Bangladesh and one from Canada. Our first speaker is Jahidul Hasan from Square Hospitals Limited in Dhaka, Bangladesh. And he is a clinical pharmacist in intensive care and infectious diseases. Our second speaker is Salmaan Kanji from the Ottawa Hospital in Ottawa, Ontario, Canada. He is a clinical pharmacy specialist in critical care and an associate scientist with the Ottawa Hospital Research Institute. I'd like to thank you both today for joining us and to share your story with all of us and your personal experiences with how COVID-19 has impacted your pharmacy practice, community, and country. Welcome.
Thanks so much for having me.
Thank you.
So we will start with the questions. Jahil, the first question I'm going to direct to you. What is the current COVID-19 situation in your country?
Yes, thank you, Linda. Very good morning. I'm Jahidul Hasan, as you introduced me, and I'm a clinical pharmacist in Square Hospital, Dhaka, Bangladesh. The current situation of COVID-19 in Bangladesh after India and Pakistan is worsened in the March and April, but nowadays is normalizing. The first COVID-19 case detected on 8 March, and after that 2 months period was the lockdown period in Bangladesh. As of August 26, I mean today, at around 0.3 million confirmed cases has been detected and recovered around 0.2 million. About 4,000 people died with a recovery rate of 61.6%, and the overall country-wise mortality rate is 1.34%. So as it is a very densely populated country amongst the world, so COVID situation is literally a very, this pandemic COVID situation is very difficult for the people here, because all the pupils are mostly middle class pupils. They are living with the local business, street workers, garments workers. The COVID situation is very difficult for them, for their living, for their accommodation, food, everything. COVID impacted a lot in their life, quality of life and the daily life. So nowadays, school and universities are closed still now, but the business, all the transport systems, some air flights are going to normalize and starting day by day. So it's a new normal situation over there. And that's all in short about the country situation in COVID-19, Bangladesh.
Okay.
Thank you,
awesome.
Linda.
Salmaan, how about in Canada?
Well, yeah, as you mentioned, my perspective is from Ontario. I work in the ICU in Ottawa, and you know, we had, just like everybody else, we went through that first phase of COVID. I think that generally speaking, Canada as a whole fared better than a lot of other countries. I think that we were fairly quick in instituting social distancing practices, and I think that as a country we were fairly good at adopting those practices and sticking with them, and I think that that's made a big difference. We noticed that in phase one, we were able to see flattening of the curve maybe earlier than some other countries. And now as we are approaching sort of this second wave, or anticipating a second wave of COVID-19, I think that we have a little bit more preparation under our belts, and I'm hoping that it's not as bad as we're seeing in some countries, and or as bad as we were originally predicting. But you know, that really remains to be seen. I don't think anybody can really predict when we're going to see this second wave. And as we go back to school, you know, my kids are going back to school. A lot of most schools in Canada are back up and running in September. And we're starting to open up local businesses, restaurants and movie theaters are back opening up, and we're allowing larger congregations of people in buildings and outside. I think that, you know, we're sort of at this transition phase in Canada and in Ontario, waiting to see sort of whether or not we as a community are able to maintain these social restrictions and keep the this virus under control, or whether or not things are going to get out of hand. In the first wave, you know, we did see a lot of deaths, but you know, I think that the community that took the worst hit was our long-term care facilities, and I'm hoping that we're in better shape if this transitions into a second wave moving forward.
Yeah, awesome. Jahidul, what steps has your hospital taken to mitigate COVID infection risk in your staff and patients?
Okay, my hospital is a Square Hospital Limited. It's a tertiary care hospital and one of the largest private hospitals in Dhaka and in Bangladesh as well. And it's a Square Group, so we have our own pharmaceuticals, Square Pharmaceuticals Limited. And the main thing that in the beginning of the COVID situation in March, we needed a lot, that is the PPE. So we had a lot, good and sufficient stock of PPE from our groups, from the government. Hospital arranged this in the beginning of this pandemic situation. We established proper trials for the safety of the patients and their proper directions. Hospital started to produce hand hygiene solutions, different cleaning solutions for its own under its own production house, and used in different areas for the staff safety and the patient safety as well. Different social distance is important part in office areas inside the hospital, and management tried to train us, every staffs of the hospital, how they maintain the social distance inside the hospital area. And the pharmacist took a very important part for the production of the hand hygiene solution, chlorhexidine solutions, and alcohol, IP-based, 70% IP-based solutions. We produced our own production, own alcohols, and distributed throughout the hospital staffs and departments, because the national crisis was there. For the patient safety, we, from the beginning at the trials, from the trials part, we differentiated who are the COVID suspected patients, who are not, from the entry point. Then we separated the COVID patients. A separated building, a 15 multi-stored building, has been completely dedicated for the COVID unit of my hospitals. Then every floor, like 13th floor, it's the completely isolated cabins. For 12 to 10th floor, it's all the separated cabins for confirmed COVID patients and moderate cases, severe cases that they are. 9th floor is the complete male and female, including male patients and female patients, is the ward systems for geriatric patients, for dependent patients. And 2 ICU setups are there. dialysis, a COVID dialysis center is there. So every facility is labor room inside the a labor facility was there. So whole building is a COVID unit. So every facility was there for the safety of the patient. No cross contaminations or any risk for the patient. So for any patients who is shifting from one floor to another, from ICU to cabins, so every covered trolley system was there for covering the patients and to save the staffs from further contamination. And we have continuous training program for the all healthcare professionals, especially done by our infection control team. And hospital authority gave us the transport facility because during the lockdown situation, no public transport was there. Then hospital arranged his own transport facilities for every staff to pick and drop. So including all these things, our staffs were saved from the pandemic. But another important issue that those staffs were affected from COVID-19, hospital arranged separated building for their quarantine facilities with foods and accommodations and free of cost medicines as well. Okay, so including all these things, this is a model setup in Bangladesh that is happening in my hospital. And last one is that we have a complete clinical management team, including a clinical pharmacist. I am working here, the doctors, so we nurses, infection control team. So we have a very well established multidisciplinary team for COVID clinical management for our patient safety and including all the tasks. Thank you, Linda.
Okay. I just have another question. What are some of the strategies your hospital has used to provide mental health support to your staff? I know, like, even the transportation
Yes.
to me would be very helpful, but is there anything else in that regard?
Yes, from the beginning, our staffs are a little bit worried what will be happen for them because they have to move to the home. Their children, fathers, my parents will be affected. Then our hospital arranged a separated accommodation systems for nurses, doctors, all and including all other healthcare professionals. Within 7 days, they developed a separated accommodation areas where doctors, nurses, and every piece healthcare professionals can stay over 14 days, and they will work in the COVID unit. So that reduced their stress a lot. Okay. Yeah. It is a very magnificent steps done by my hospital, I think.
Wow, impressive. Okay. Saul, what's going on in your hospital to mitigate risk and infection?
Wow, not that much. That's pretty impressive. Yeah. We definitely did not open up a second hospital or building dedicated to COVID patients. We did do a number of things that I think a lot of other Canadian hospitals did. We had early restrictions on PPE use when PPE was in shortage, and that relaxed once we started getting PPE shipped in from other countries and from other provinces, and that made a big difference. Specifically in our ICU, and in our hospital, we had to set up dedicated areas for COVID patients. In the ICU, we divided our unit into two halves. One would be a COVID side and one would be a non-COVID side, and we restricted movement between the two sides to minimize the risk of transmission for both patients and for staff. We changed our rounding model such that before we used to do bedside rounding on every patient, and now we're doing rounding in a conference room, and the nurses come to us instead of us going to the nurses and the patients. Which has its advantages and disadvantages, but definitely does reduce the risk of transmission from going bedside to bedside. And then we've developed policies and procedures for aerosol generating procedures that are done in the hospital, whether it's endoscopy or tracheostomies at the bedside in the ICU. We've got new policies and procedures in place, and we did all kinds of mock models and run-throughs to ensure that everybody is familiar and comfortable with the sort of new way of doing things. And then, if in terms of patients, we had fairly significant restrictions on visitations in the hospital. We had, all of our ambulatory clinics were closed, and follow-ups and visits were done virtually wherever possible. And that was a huge change. And adaptation, not only for us, but I'm sure for the patients as well, not being able to actually come into the hospital and talk to your doctor face-to-face, or follow up on your tests in a face-to-face manner where patients are more comfortable. And so that's been some of the things that we've done to challenge, that have been sort of a challenge for both us and patients in our hospital.
Excellent. Again, what are some of the strategies your hospitals use to maybe help with the mental health support for your staff?
Well, I think that the mental health, the stressors from a mental health perspective have been significant. We've dealt with staff shortages, we've dealt with drug shortages, we've dealt with being over capacity in our units. And being worked fairly hard, and then sort of trying to maintain, being safe at home, and then coming into work every day. So that's been a significant challenge. Our hospital has acknowledged that. They've made some efforts to provide mental health services to patients. But there's been a lot of sort of little things that have come from our communities, which surprisingly have made a big difference. We've had a lot of donations in the last little while. We've had, local restaurants and local people within our community saying they want to give back a little bit, whether it is providing meals for our nurses and staff in the ICU, or whether it is providing donations of PPE, or, we had a lot of homemade masks made, and headbands to clip your masks to, and also all kinds of support from our community that was facilitated by our hospital. And so that's made a significant difference. There have been a few initiatives from our hospital to sort of increase morale, whether it's free coffee from Tim Hortons or free parking for staff that have contributed as well. But I think this is an ongoing process, and the longer this lasts, more is going to be necessary, I think.
Yeah. Wow, that's interesting. Thank you. Okay. Jahidul, before COVID-19, what was your normal clinical practice like in your pharmacy setting? What did it look like?
Okay.
Can you remember that far back?
Yes, yes, it's not a long before, because I started clinical pharmacy in 2015, and my hospital tried to establish this clinical practice since its inception in 2005, but due to some construction limitations and some managerial problems, due to lack of proper pharmacist availability and other issues, we didn't start it. But when I joined in 2013 in Square Hospital, and I started to move to ICU. Then this is the first starting point of my career, and even the clinical pharmacy in Bangladesh as well. I started to move to ICU. One of it's the in charge, Dr. Rahan Dabbani, one of the in charge physician was there. He tried me a lot. He started to support me, and I found my ground. I started to roll my I want to roll my activities. after a few years, around 2 to 3 years later, I developed the clinical pharmacy and critical care clinical pharmacy service over there. Then other departments were interested, management was interested in me, how I developed these things. My department supported me well. Then finally, we developed a new service division that is called Clinical Pharmacy Service under Department of Pharmacy. And along with the ISO department, other critical areas like SDU, I mean high dependency unit, respiratory medicines, non-clinical areas, respiratory medicines, nephrology department, I started to work there. It's an initiation in clinical pharmacy in Bangladesh, and I tried to establish this profession since 2015. And just before the COVID-19, my duty was to take part in the ISO grand round. And I went to different floors and different critical areas where, because doctors asked me to come and to see the patients and give my suggestions. I went there and gave suggestions to the doctors what they want from me. Some adverse drug reaction, doctors a little bit worried about the case. Then I went there and found the actual cause. These are the activities and some nursing education programs. I took these classes and trained them. And other pharmacist training is my duty because I, as a clinical pharmacist, I know the patient safety, patient management, and they are doing the dispensing. So it's a combination for the better pharmacology, pharmaceutical care, basically. And nowadays, around 40 to 50 patients I serve every day before COVID-19. And I have few interventions record published as articles and in different journals. And I try to convince my doctors that if you want to take some advantages from clinical pharmacist, you can ask me. And it's a very good scenario that doctor asked me from different departments, and I supported as much as I can. So nowadays my department is looking for taking or hiring more pharmacists in clinical pharmacy, and I disseminating before COVID-19, it was my regular practice that I disseminating my experience and other activities, my cases to other university students, other hospital pharmacists in different hospitals, to establish clinical pharmacy in other hospitals as well, and to increase the educational interest or professional interest regarding clinical pharmacy among the university students as well. But due to COVID-19, the outsider activities has been completely stopped. Now I am fully concentrating in the COVID-19 patient management as a frontliner with the primary care team. Thank you, Linda.
Okay, thank you. And is there any operationally, any other things that have changed with your day-to-day stuff with COVID-19? Or is that?
Definitely. Before COVID-19, I went to the general building, general floors, general critical areas. But nowadays, I have to spend at least 4 to 5 hours in the COVID-19 round because I have to move patient to patient, every patient. I participate in the grand round with other doctors and nurses. Then it takes around 4 to 5 hours a day. Okay. Around 100 patients has been admitted here. So I have to move 100 patients. So that's why it takes 4 to 5 hours. Then patient counseling, discharge patient counseling. As I am staying in the round, so I know which patient is discharging. So I move to the patient and I give my discharge counseling to the patient. Sometimes patient want to know the drugs he or she is getting, because due to steroid, his blood glucose level is going up. So some drugs making some problems, some drugs making some unusual events in patient, and patient asked that I need someone to come and to discuss what the problem I'm facing. Then I move to the patient during the round time or after the round time and make him clear that this is due to the steroid or this is due to the this drug problem. And try to resolve the case and to relieve the patient from the panic and other issues. And basically my participation is now for the drug safety and better pharmaceutical management and drug therapy management in the COVID patients. But before that, it is a non-COVID practice completely. Thank you.
Okay, Saul, what was your practice before COVID and then after COVID?
Well, my practice before was a lot more predictable, that's for sure. I have a unique position here in Ottawa. I am 50%, I spend 50% of my time in the ICU as a clinical specialist. And in that context, I'm part of a multidisciplinary team that takes care of about 20 to 30 patients at a time. And the other half of my job is I'm a clinical epidemiologist, and I spend 50% of my time doing research. So most of my research is in critically ill patients with a focus on pharmacotherapy, medication safety, and pharmacokinetics. But I have a fairly broad scope of research practice. So that's kind of what it was like before. Once COVID hit, as a hospital, we kind of put a slowdown on research. And so I gave up my research weeks and went I did clinical work full time. Surprisingly, there was more research activity during COVID than I anticipated, and I was probably just as busy doing research activities during COVID as I was before, when I had dedicated time. But for the most part, pharmacists here in Ottawa and in Ontario play a strong clinical role, particularly in the ICU, where we are integrated members within a multidisciplinary team.
Awesome. Okay, maybe Saul, I'll start with you this time again. And what are some of the new ways you're treating the COVID-19 patients, or how have you adapted your practices to treat them, and what are the challenges you've had with that?
Well, I think that we're doing the same thing as everybody else in terms of therapeutic choices, with antivirals and steroids and anticoagulation. I think those are really the three things that we focus on a lot. But some of the challenges in delivering that care has been dealing with some of the drug shortages. And so I feel like we've got a greater awareness now that things like sedatives and analgesics and paralytics are generally in short supply, and we play a greater role in identifying which patients in whom those are most necessary, and where we should be using those precious resources. And the other thing that we've been doing in terms of clinical care is we've been enrolling patients into clinical trials, right? So there's so much uncertainty as to the benefits of certain therapies. I think the responsible thing to do is to enroll these patients into clinical trials, whether we're talking about anticoagulation or antiviral therapy. These are still unanswered questions, and I think the responsible thing to do is put these patients into clinical trials. I work in a large enough hospital where we have these trials running at our in our institution, so we're at least able to do that. So that's what that's been two of the biggest challenges and differences in terms of caring for these patients that I can point out.
Jahidul, how about you? What have new ways of treating them? What have your challenges been in adapting to treating patients?
Yes, it's a big challenge because there are different types of patient management in COVID care unit. Initially, we didn't have remdesivir or any antiviral drugs, but after 1 month later in April, we found the remdesivir, favipiravir, these drugs. Nowadays, in my hospital setup, we are using remdesivir as antiviral drug, and in the outdoor there is favipiravir, or ivermectin somewhere in the society. Ivermectin is very common drug, ivermectin. And another important drug that is tocilizumab, Actimra. We are using it in the severe COVID-19 pneumonia management because we found a very good outcome from this medicine. Tocilizumab, basically 2 doses, if we apply in some patient, we generally found around 50 to 60% patient, we found very good clinical outcome. And we restricted the patient from going to the ICU. Another janus kinase inhibitor, baricitinib, we are using. And it was my protocol that because baricitinib is not a very stronger drug like Actimra, but it is doing some bringing some good clinical outcomes in our patients. It's an oral dosage form. Cost is very less, so people can easily agree with this medicine. But tocilizumab is very costly. Many people in my hospitals and other hospitals cannot bear the cost of this medicine. So it's a big issue. So other medicines, as I am a clinical pharmacist and our clinical management team and the guideline management team, so it's my sole responsibility to see the all drugs, its dosing, its management. Like doctors asked me, Zahid, can we give remdesivir in pregnant women? Can we give remdesivir in the ESRD patient? Can you give the tocilizumab in the 27-week pregnancy? Then I have to give the decision within a minute or within an hour that what I want, what I suggest to them. Then according to my suggestion, the doctors take the decision. And somehow, and sometimes I take part in the medical board as well. So this is a very challenging issue at this moment to because these drugs have very limited clinical informations over around the world, but I have to give decisions. So I have to give decision on my basic knowledge and experience. So this is the big challenge. Other drugs like steroids, I have to see the drug safety of steroids, its associated clinical adversities. And anticoagulation is a big issue, as Kanji said, that it's a big issue because we are using enoxaparin, basically low molecular weight heparin, in COVID patients. So its management, drug safety, its interactions, everything I have to take care. So including all the COVID medicines, including steroids, it's a critical case to handle for any pharmacist like me. So it's a exceptionally different experience. Thank you, Linda.
Yeah. Do you have drug shortages in your country that are affecting your practice?
Not at all, because one of the best support is from our own pharmaceuticals, pharmaceuticals, because they produce especially some essential medicines like steroids, like anticoagulation drugs. Those are in some hospitals, these are a very crisisful drug. Okay, but in my setup, we are very fortunate that our pharmaceuticals is providing these drugs to as a one-stop service from pharma to our hospital. So at Square Hospital, we are very lucky that we have very short times of shortage experience. But we had a shortage experience of remdesivir because it's very limited supply, and tocilizumab as well. Sometimes we are unable to dispense this drug to the patient because drug is not available in the country. So otherwise, general medicines, it's very common still now.
Interesting. So you alluded to a little bit the drug shortages. Did you want to add anything to the drug shortages that you've been experiencing?
Sure. You know, during that first phase of COVID, we had significant challenges with drug shortages. And then, specifically with related to sedatives and narcotics, we found that COVID patients who were intubated required extremely high doses of sedatives and narcotics in order to facilitate mechanical ventilation. And we ran out very, very quickly. The way it works in Canada is that our allotment from pharmaceutical distributors is based on past usage. So, prior to COVID, we would get a regular allotment of propofol or midazolam. And during the COVID time, when our usage went up by 300, 400%, the distributors weren't able to accommodate that increased need. And so a lot of the bigger hospitals in Toronto in particular, Montreal, which is near Ottawa here, they had significant shortages. And with all kinds of drugs, speaking with some of my colleagues in Montreal, they were running out of all kinds of things, including things like nystatin, which you would, you wouldn't really expect as a. The reality is that when you overflow, when the ICUs are full and you're looking at extra space and doubling and tripling your capacity, you're going to run out of all drugs, and so we as a province came together and. There was a provincial ICU drug shortage task force that was put together that was tasked with the job of figuring out how to share drugs between hospitals within the province. And I think that we're in good shape moving forward, but we definitely had some challenges with that first wave. And we were, we even had to bring in drugs with Health Canada's approval that we haven't seen in decades in this country, specifically related to neuromuscular blockers like pancuronium. We haven't used pancuronium in Canada for more than 10 years, and in a pinch, this was made available to us should we need it. So it's an interesting time in terms of shortages of drugs. And so not only that, but we've had to develop strategies to minimize wastage and conserve drug as much as possible, so that we're using it in the right scenarios.
Very interesting. You also had talked a little bit about the research, and I was wondering if you could add more to what your hospital is contributing to research around the new COVID-19 treatments.
Sure. So, we've done, our hospital is involved in a lot of research around COVID-19. We have active trials enrolling patients into antiviral studies, into anticoagulation studies, and steroid therapies, antibiotics for super infections. And so we're fairly active in terms of research in that sense. Pharmacists have also been fairly involved in this process as well. In the ICU, I'm involved in a trial where we are giving patients propranolol to reduce propofol requirements as a centrally acting adrenergic blocker. So. So we've got a few things like that on the go, and then also, we've been fairly involved at the provincial level developing guidelines for conservation strategies, and these were recently published in the Canadian Journal of Anesthesia.
Wow, very interesting. Jahidul, how about you? Research with the new treatments in COVID. Are you involved, or some of your pharmacy people?
Yes. Our hospital is not an academic hospital, it's a corporate hospital. And research is going on with our own interest. I am with a few of my doctors. We started some research because we have a stewardship program, as I'm the coordinator of this stewardship program. So under this stewardship program, we try to initiate some studies on our infections, secondary infections, super infections in our COVID patients. Some in the medicine department, we started to make some research on our existing drugs we are using in our COVID patients, like tocilizumab, baricitinib, some steroids, anticoagulation drugs like enoxaparin and dalteparin. So I am doing research under my own supervision, that is the tocilizumab, how it makes difference in the clinical outcome in COVID patients, in critical and severe COVID-19 patients, and baricitinib on the clinical outcomes. And I think this is a very interesting topic for the global scientists, how baricitinib is making difference in COVID-19 patient management. So still today, around over 1,000 patients we treated well, and we have a death rate, very minimum death rate, below 2%. But research is in two parts. One, research is we are doing among our setups, that what the drugs we are using, what the outcome is, a monitoring base. Another one is the publication. So as we are very busy, we cannot spend most of our time in the research activities, but parallelly we are doing some research, still 3 research under peer review, and drugs in COVID-19 and its clinical outcome is the main target of these research activities. Thank you.
Wow, thank you. Well, that's all the questions I have. Maybe I will stay with you and ask, do you have a key message for your patients or your fellow pharmacists that you would like to share with us?
Yes. One thing is that for patients, first I want to say, don't be panicked, because patient I found in my country, if they get positive result, they become very nervous. What is happening? Some patients, when they inform that their result is positive, they are crying. So I should say they should take it as a very positive, in a very positive way, that it's a treatable disease, and the mortality rate is very low. And another important is that for the pharmacist, that is, it's a time for all pharmacist specialties to show their capability and potentialities and professionalisms in the clinical management, and to support to doctors and other healthcare professionals in the pandemic COVID-19 management. And this impression in future will make a very big difference in the global pharmacist contributions, I think so. Thank you, Linda.
Awesome, thank you. So, do you have a key message you'd like to share with us?
Sure. I think that the most effective management strategy that we've found so far for COVID-19 by far is social distancing and wearing masks. And for patients, I think that we're in a critical state right now where we're opening up a little bit as a community. We're trying to normalize things and go back to business as usual. But the reason why we've done so well so far is that at least Canadians have been diligent in social distancing, wearing masks, following the rules, and asking appropriate questions. And I feel like now we're seeing around the world that these restrictions are relaxing a little bit, and people are sort of forgetting what worked in the first place, and these numbers are starting to rise again. And so from a Canadian perspective, I think that's so important that we continue to be diligent with wearing masks and socially distance as we start sending our kids back to school, as we start going back to work, as we start opening restaurants and movie theaters and businesses around town. And I think that if we can keep on top of this, then maybe we won't even see a second wave, and that's my hope. And as for pharmacists and other clinicians in the hospital, I think that I don't think that we're going to go back to the way things were before. I think that this is serendipitously forced us to evaluate our practice, forced us to evaluate our workflow through healthcare, and things that have changed. Some of them are going to stay that way. I think that ambulatory care is going to have significant changes moving forward. I think that we've recognized that some patients are better suited for distance follow-up. Not everybody needs to come into the hospital to see their doctor. I think things like that are going to change a little bit. And I think that we've also recognized that there are inefficiencies in our workflows, and you know, when you go through a pandemic and you're working with, you know, 70% of your normal staff, you've found better ways to optimize workflow in the hospital. And I think that those things need to stay. And so I think that, you know, we're sort of, again, sort of at a transition point where I think pharmacists have an opportunity to look at the changes that are happening around them and try and find ways to adapt so that we can continue to move clinical pharmacy forward as healthcare changes.
Awesome. Thank you. Well, this concludes our webinar today. And I want to offer my sincere gratitude to both of you for sharing your insight and experiences to me and to all of our viewers today. So hopefully through sharing some of these experiences, we can understand a bit better how our colleagues around the world are coping during these difficult times. And maybe it'll help us realize, even though there are some differences, we have a lot in common and that we're in this together. So thank you so much to both of you, and stay safe.
Thanks so much for.
Thank you, Kanji. Thank you.
Very nice. Awesome.